Welcome to this lesson on myocardial infarction and device therapy. My name is Ardan Zaguner, and I'm an attending physician at the University Hospital in Zurich in cardiology with a special interest in cardiac electrophysiology. The topic of this presentation are cardiac devices in patients who have suffered from myocardial infarction and who have developed heart failure, namely the implantable cardioverter defibrillator, ICD, and cardiac resynchronization therapy, CRT. This presentation is based on the 2016 guidelines on heart failure by the European Society of Cardiology. On the left side, you see an apical four-chamber view on transthoracic echocardiogram in a patient with a normal heart. You can appreciate that all four chambers are normal in size and in function. On the right side, you can see the same view in a patient who suffered from myocardial infarction and who has developed heart failure with reduced ejection fraction. The left ventricle is significantly dilated and the function significantly reduced. Heart failure is very common in the industrialized world, and its incidence is increasing by age, reaching up to 17% in patients older than 85 years of age. The incidence of sudden cardiac death is low in the general population, but significantly increases in patients who have suffered from a myocardial infarction, and is particularly high in those who have a left ventricular ejection fraction of 35% or less. Therefore, in these patients, device therapy is important to reduce sudden cardiac death and to improve morbidity. The implantable cardioverter defibrillator, ICD, is a special form of a pacemaker that can be implanted in the left or right subpectoral position, with leads being placed through the venous system, the axillary vein, the cephalic vein, or the subclavian vein, with the lead being placed in the right ventricle and a second additional lead being placed in the right atrium. This device is able to terminate rapid ventricular arrhythmias, such as ventricular tachycardia or ventricular fibrillation, and thereby save lives. Cardiac resynchronization therapy, CRT, is a special form of a pacemaker or defibrillator that has an additional third lead that can be inserted via the coronary venous system and is being placed on the epicardial surface of the left ventricle. This device can resynchronize the heart, thereby narrow the QRS complex, improve heart failure symptoms, and reduce mortality. So how does the ICD work? The ICD can detect rapid ventricular arrhythmias, such as ventricular tachycardia in this case. It will first try to suppress this arrhythmia by the so-called anti-tachycardia pacing that is painless. This is often successful, but sometimes the tachycardia can degenerate into ventricular fibrillation, or ventricular fibrillation can primarily occur. In this case, the device will charge up to 40 joules and deliver a high voltage shock that can terminate the tachycardia, returning the patient to sinus rhythm or post-stroke pacing. From 3 large randomized clinical trials in patients who have suffered from sustained ventricular arrhythmias in patients with a myocardial infarction, and a meta-analysis of these 3 large trials, we know that in these patients the ICD will reduce all-cause mortality by 28%. So in this secondary prevention cohort, ICD implantation is a class 1 indication for implantation. From the SCATEF trial, we know that also in patients who have not previously suffered from sustained ventricular arrhythmias, in the so-called primary prevention cohort, but who are symptomatic with New York Heart Association class 2 or 3, the ICD will reduce all-cause mortality by 23% as compared to amiodarone. The number needed to treat in patients with New York Heart Association class 2 is 50 in order to prevent 1 death per year. Therefore, ICD implantation is indicated and a class 1 indication in the current guidelines in these primary prevention patients. So what about primary prevention patients who are asymptomatic? The MEDIT trial has shown that in patients who have suffered from myocardial infarction and who have a left ventricular ejection fraction of 30% or less, the ICD will reduce all-cause mortality by 31% as compared to conventional therapy. Therefore, in primary prevention in asymptomatic patients, with a left ventricular ejection fraction of 30% or less, the ICD is a class 1 indication for implantation. Let's come to cardiac resynchronization therapy, CRT, in patients who have suffered from a myocardial infarction and who have developed heart failure with reduced ejection fraction. CRT is indicated in patients who have a myocardial infarction, a left ejection fraction of 35% or less, and a broad QRS complex, ideally in patients with the left bundle branch block and a QRS duration of over 150 milliseconds. In these patients, by placing a third additional lead on the left ventricle, the QRS complex can be narrowed and heart failure symptoms can be improved. From the CARE-HF trial, we know that CRT in patients with heart failure can reduce all-cause mortality by 36% as compared to medical therapy. Of note, in this trial, the majority of patients had a CRT pacemaker and only the minority had a CRT defibrillator. We also know from the CARE-HF trial and other studies that the broader the QRS complex, the better the improvement of symptoms and mortality in patients. Therefore, patients with the left bundle branch block and a QRS duration of over 150 milliseconds particularly benefit from CRT treatment. On the opposite, from the ECHO-CRT trial, we know that patients who have suffered from myocardial infarction and who have heart failure with reduced ejection fraction but a narrow QRS complex, the CRT device will not improve morbidity and mortality. Of note, in this trial, there was even a trend for increased mortality in patients that were treated with the CRT. Therefore, in the current guidelines, CRT is not recommended in patients with heart failure and the QRS complex of less than 130 milliseconds. I'd like to conclude my presentation. Device therapy is very important in patients who have suffered from myocardial infarction and who have heart failure with reduced ejection fraction. The ICD can terminate rapid ventricular arrhythmias by delivering anti-tachycardia pacing or ICD shocks, saving lives, and CRT can resynchronize the mechanical contractions of the left and right ventricle and narrow the QRS complex in patients with a broad QRS complex, ideally in patients with the left bundle branch block, and thereby improve heart failure symptoms and reduce mortality. Thank you very much for your attention.